Hello students, today we'll have a common condition case discussion. Just have a look and identify the disease. What is this clinical finding is? Look at that. This is the perianal region. This is the lesion here. This is the anal canal. So what is this condition is? What is this? Look at that. It is fistula in ano. What you see here is external opening. You can see that external opening. So it is a tubular structure connecting from external opening towards the internal opening due to infection in the cryptoglandular tissues or glands. So there are different causes which I am going to discuss. So look for what? Internal opens. Very, very important. You have to do digital rectal examination, otherwise called as PR, per rectal examination, especially in the posterior midline. It is a very common site of internal opening. And many times if fistula is anterior, it can be radial along the site. That we will discuss later. So it can be cryptoglandular. There are glands, water glands called as cryptoglands, hidden glands, just related close to the dentate line and in the intersphincteric space, internal sphincter and so on. These glands secrete some fluid, and these glands get infected, usually forms an abscess after suppuration, and once it gives way or after drainage by a surgeon, it becomes fistula in ano. It forms fistula in ano more or less very, very commonly. Many patients it may heal on its own after drainage, but most of the patients, majority of patients will lead into the what is called as fistula in ano. So other causes are non-cryptoglands. There are Crohn's disease, tuberculosis, trauma, malignancy, ulcerative colitis, LGV, and so on. So this is the classification which you have to remember. Pars classification. Intersphincteric is the common. In between the two sphincter, it goes like this. Transsphincteric is like this. If this is the thing. This is the intersphincteric. Transsphincteric is like this, and supraelevator goes high up, and extrasphincteric is like this. It comes like this. So these are the four types. And this is the most common. This is okay. This is rather dangerous. This is still dangerous. It requires very aggressive treatment, staged procedure, and so on. So remember, there are so many classifications. Remember Park's classification. That is the standard. So simple and complex. The low fistula, single track. They are called as simple fistula. Fistula extending more than 3 centimeter. Anterior fistulas in females, fistula due to any specific cause like Crohn's disease, tuberculosis, multiple openings, horseshoe fistulas. All these fistulas called as complex fistulas. So how we evaluate? I said clinical, digital, rectal examination. Most important. You assess look for internal opening, assess the external opening, look for the sphincter tone, look for any induration for the infection or collection and so on. So this is the basic thing. You have to do rectal examination, often proctoscopy also. Then of course ideal investigation is MR fistulogram. It denotes near 100%, gives the accuracy of the track, extensions, how many are there, simple or complex, sphincter nature, all those things. But sometimes imaging, reporting may be wrong. So ideally you only read the MRI or MR fistulogram and correlate to the patient as such. And discharge study, biopsy, endosonography locally also equally useful. Colonoscopy in a suspected Crohn's disease, ulcerative colitis, if you are suspecting malignancy, long-standing fistulas, then do a colonoscopy also. Anal manometry to identify the sphincter tone, sphincter pressure. That is also quite useful. So Goodsall's one rule is very important. Often asked as MCQ for students is Goodsall's rule. Anterior fistulas are radial and straight. Posterior fistulas are commonly curved, but always opens in the midline. This is the midline, where this is radial, where this is curved and open. So this is the commonest site. Posterior midline is the commonest site of internal opening, which you have to look for. In 1900, Goodsall started this rule. Still holds good. There may be some shortcomings, but still holds good. Anterior fistulas are radial and straight. Posterior fistulas are curved and always internal opening will be in the midline. That point always you have to remember. So how to treat? Different procedure. Fistulotomy is lay opening of the fistula in the simple low fistula. Is still gold standard. and you can curate everything. You can mercifully the edge so that it don't cause a bridging effect and cause recurrence. And fistulectomy is equally effective. There is no difference between the final evidence-based efficacy as such, where you remove the tract. Advanced local flaps in the recurrent fistulas and difficult fistulas you can do. You can mucosal advanced flap you can do, or anal dermal advanced flap you can do. Sit-down technique is still good, quite good in useful many patients, especially fistula across the sphincter, fistula going above the sphincter, where you cannot afford to get incontinence. Colostomy in a very high extra elevator, recurrent fistulas, you have to do colostomy, divert the fecal matter so that to prevent contamination. Then do the definitive procedure as a stage. Once everything is healed, which you will evaluate by MRI or other methods, then only you close the colostomy closer after 6 months and so on. Anal fistula plug, it is the porcine submucosal, intestinal submucosal matrix, which contains 90% collagen, where it scaffolds, remodels and increases the healing. Lift is a ligation of the intrasphincteric fistula. In a transsphincteric fistula it is useful, but only thing is internal opening you are not addressing, that is the problem. Video assisted anal fistula track, we got fistuloscopes are available which are rigid. Through the fistuloscope we can go through the fistula, we can give a good wash, we can irrigate and we can fulgurate the track, but only thing is large track, curved track and extensions you may not be able to reach, may cause recurrence. So you have to always club, we have to do other procedure along with that, so that as a hybrid procedure you have to do. Laser, fistula laser closure also quite useful, again same principle, you fulgurate with the fistula laser, fistula track. Important thing is internal opening should be addressed always. But so many methods are there, suturing, clipping, submucosal suturing, closure, all those different procedures are there. And then of course address the external component. So proximal fistulotomy, closure of the internal opening, then addressing external component, prevention of recurrence. Maintaining the sphincter complex tone, that is also very important. It should not get incontinence. And recurrence chances as much as possible should be avoided. Gluing also another, but high recurrence rate is there. Hybrid means you combine many. Do a fistulotomy, do laser, internal opening closure, then other procedure or plugging, whatever it is. So hybrid procedure. Now recent one is the stem cell therapy, whereby mesenchymal stem cells are extracted from the patient's own fat cells or what are different tissues, and that is being solutions are impregnated into the fistula tract, which gives the support, scaffolding, remodeling and seal the fistula completely. So it is the future of the management of the fistula. There are so many procedures. Sit-on is very good technique. Many sit-ons you can put, two types are there, loose sit-on, cutting sit-on, all those things you can read in the book. Which is the basic thing you have to remember. Important thing is close the internal fistula, internal opening. And proximal fistula should be laid open properly. And extension should be laid open. Avoid injury to the sphincters, very, very important. Try to reduce the recurrence. Control the infection completely, curate adequately. So complications are incontinence, recurrence. That's the important thing. And specific causes if there are Crohn's or tuberculosis, that should be addressed, not just fistula as such. So I told already complication fistula is a very, very common thing. Any patient comes, please go through my clinical book, how to examine it is there. Go through my surgical, SRB surgical manual of surgery, 7th edition or current edition. In detail, everything is there, photos, methods, everything is there. And operative procedures gives you clear idea about the fistula. Tissue suturing also it is there. My DigiNow contains around 220 lectures and including clinicals, everything about surgery, A to Z, all topics, fistula, anal, operative surgery and X-rays, specimens, instruments, everything it is there. So please go through this one. So these different available materials so that you can have the better idea about the surgery as such. So students, I hope you have understood basics about the fistula in Thank you very much.